Well, thank you very much, Dr. Tavakoli and the SAGES, for this opportunity to present, and to all you brave souls in the audience. Just disclosures, nothing pertaining to this presentation. Just as an overview, I thought I'd try to highlight 3 areas, looking specifically at trying to entertain and determine what are the risk factors for conversion, if we can at this time, specifically in my field, colorectal surgery, and then also outcomes associated with conversion. And then lastly, and if this is probably another disclosure, the new risk calculator, and I love gadgets on the computer, so that's my other disclosure. I saw this and it was hook, line, and sinker, so I'm going to show that to you today as well if you have not seen it yet. So when we start off, I'm going to try to use mostly randomized controlled trials, but this is our experts, many leaders here at the meeting today, many past presidents who actually participated in this clinical trial. But you can see early on in experience, there was a relatively high conversion rate, upwards of 25% for colon, and for rectal cancer, 34%. And then if we look at the potential impact of robotics, I think that robotic procedures may be selected, but at least in rectal cancer, where the conversion rates were higher with the initial laparoscopic multi-center trials, there may be a role here in robotics for reducing the conversion rate. And certainly in this paper, they had a 0%. My own personal series, we don't have 0, but we have significantly less than 10% even. So I think that that is coming when the roller trial and some of the other trials come out, like the CLASSICC Z6051. So when we look at some other clinical trials, when I just look at the most recent, and again, this is a single institution experience, we start to get back up in that 16%. And the factors that this group outlined were BMI, the date of the operation. So again, if this is a new learner, their initial experience is going to have a higher conversion rate than their latter experience. And then specifically related to tumors, a larger tumor, if you have a 7-centimeter tumor, it's pretty difficult to excise that out of a 3-centimeter extraction incision. So many times it's also difficult to lift that 7-centimeter tumor or higher. And then also the rectal location being more complex for sure with the laparoscopic approach. And again, looking at this study, kind of those same themes coming along. So tumor, date of operation or surgeon experience, and again, tumor size in this study greater than 5 centimeters, and the conversion rate in this single institution series was 12%. So we started to kind of just keep hanging out in this teen percent range. In this study, they also found that when we specifically looked at the outcomes, when conversion occurred, there was an increased blood loss. And again, I'm not necessarily sure that the conversion causes blood loss, but likely the reason for conversion was blood bleeding or some sort of complication requiring conversion. Increased surgical site infection, we're going to have a larger wound, so that's not a surprise there. And then also 30-day mortality rate is slightly increased. And then decreased overall survival from a cancer perspective. And again, this may be that potentially the tumor was too large, or this may have been a tumor that was locally advanced or metastatic to begin with. So that may be a reason for the decreased overall survival. I think this is probably the way that we should move away from BMI and actually towards central obesity. I always joke with my residents when we're starting the case, I think, oh my goodness, I think this patient's gained 20 pounds since I met them in the clinic. But the whole girth in the abdomen is just sitting right there once they lay flat on the table. Even when I examine them on the table in the office, for some reason they just seem like they have gained their central girth a lot more when they get to the operating room. But this was a very, I think, well thought out study, and also helps us think of things differently. I remember when I was a resident and we were on transplant, and there was a donor that had a BMI of 35. He had just gotten back from a tour in Afghanistan. He was a Marine. He was the most fit individual in the world, and had unfortunately been in a motorcycle accident. Best potential donor ever, and he got turned down by 10 prior areas just because of his BMI before we were offered the case. So I think BMI is really antiquated, but it's so ingrained into the way that we speak, the way that we assess, and all of our outcome measures. But if we look at this, in this central obesity, their conversion rate again in the mid-teens, And the reasons for conversion in this study were attributed to adhesions or bleeding, visceral injury, obesity, larger tumor again, and then some other factors. But this is kind of that central obesity picture, kind of thin legs, thin arms, but everything right in the midsection. So that's a more difficult operation for sure. And when we look at their measurements, you'll notice that from my perspective, this was actually a fairly lower weight, lower BMI study. Only 18% of these cases were actually had a BMI greater than 30, what our definition is of obesity or morbid obesity. So you can see that BMI is not really catching those cases that may have an increased rate of conversion. When we look at the other factors, male sex, COPD, metabolic syndrome, again, kind of that syndrome X picture, central obesity picture, and you can see when they actually looked at the weight circumference and the weight-hip ratio, that was statistically significant for complications and conversion. So again, just really driving the message home that while we are ingrained in BMI, it's either set too high as a risk assessment, or we need to convert to the waist circumference or waist-hip ratio measurement. When we look at the national inpatient sample, specifically looking at potentially higher risk cases, there definitely was a higher risk conversion rate. This is Dr. Stamos and his group looked at the sample from UC Irvine, and over just shy of 9,000 cases, laparoscopic cases about 3,000. And they defined high-risk patients as being older than 70, BMI greater than 30, and patients who smoked. Major criteria were significant comorbidities. I think all of us would agree that this increases the complication rate, makes the patient higher risk. And you can see that laparoscopic and open converted pretty much equivalent across the board. There's nothing really different here on this slide. But it does show that when the case did need to be converted, there was an obvious increase in length of stay. They were able to calculate the total hospital charge with this. I think most importantly, there was equivalent mortality. So laparoscopic in these high-risk patients is not a poor judgment approach for this patient population. But they did have a higher rate of complication when converted, again, kind of moving from the lap to the open complication. And then converted compared to open cases had a higher total hospital charge and trend towards more acute renal failure. This trial will be publishing soon. We were looking at reducing anastomotic leaks, but conversion rate was another factor that we monitored. And I think we're going to start seeing this lower rate of conversion in the next round of clinical trials, less than 10% likely. This was our conversion rate for this trial led by Dr. Stamos. So a scoring system, is there anything that can help us predict who's going to have a higher rate of conversion? How can we counsel our patients? How can we counsel our OR staff? What equipment do you need to have on standby? How much laparoscopic equipment do you open? What's your assessment of whether you're going to have to convert on this patient? So this looked at about, again, their own single institution series, just shy of 500 patients, again in that mid-teen % conversion rate. Their independent risk factors were age. Again, early on in the experience was a higher risk factor, and tumor size, tumor invasion, prior abdominal surgery, and BMI. And what they basically looked at, and were able to fix certain values to patient age greater than 65 or prior abdominal surgery, and then notice that kind of the shift point as far as their scoring system was less than 18.5 was a conversion rate of 5%. But if you tallied all these numbers up and your score was greater than 18.5, the conversion rate was as high as 43%. So while this is a little bit cumbersome, I honestly don't have this written down or in my pocket or anything like that, but it kind of, you can see visually that these things are easy to remember. So be a little bit heavier, a little bit older, prior abdominal surgery, you're already, over 18%. So you can start counseling your patient and your OR staff with some of these numbers. And again, here's my newest toy, and my nurses have to get me off the computer sometimes because I'm playing with this so much. And she's basically told me I'm not allowed to do this in clinic anymore, and I have to do it before clinic so we don't slow down. But this is very easy. You can Google risk calculator or ACS NIST risk calculator. You have to read the fine print, check the box, push continue. But you get to this pretty easy, and a lot of the same factors that we've been seeing pop up in some of the studies that we've looked at. And you basically just fill out this area, You can type the procedure if you know the code, that's faster. And then it generates a pretty nice, you can print this out for your patient. You can actually email it to your patient directly from the site, and it gives you a pretty reasonable estimate. So we just took open right hemicolectomy as an example, picked a relatively healthy patient, age less than 65, male, some hypertension, some diabetes, but no past myocardial events, COPD, steroids, or smoking. But you can see even basically the incision is the biggest issue here, is an 8% surgical site infection, which again piles into any complications, increasing that, and then serious wound-related complications. Now compare that to laparoscopic right hemicolectomy. And again, the incision can make a reduction by 8% just simply related to the wound. And when you compare those head to head, while these numbers may not appear so dramatic for a single patient, if this is your volume of cases to be 100, 150 as you, the single surgeon every year, or for your hospital, 500 plus cases, these numbers add up dramatically and are pretty substantial. So I think we're starting to get into the era where we can not only help educate our patients, but our staff, but really finally having some concrete data, not only our own knowledge of our own postoperative complications, but across the nation. So I think over time, the conversion rate has decreased, but any series that's published that's a single institution series is really showing you the learning curve. So I think they're naturally going to have a higher conversion rate when reported when compared to a randomized trial or a multi-center trial. So I think as we're moving more towards a randomized multi-center trial, the numbers are going to go down just because of that fact. So risk factors, again, age, central obesity, tumor size, or potential local invasion or metastasis, and again, early on in experience. Outcomes associated with conversion, no question, increased length of stay. It's really an open case at that standpoint, plus the equipment for laparoscopy that wasn't fully utilized, and the complications associated with an open surgery. But again, it's not really a question of the conversion causing these, but really the underlying disease, likely comorbidities associated with this. And then it's in the category of open surgery. And then just you seeing that risk calculator, you can see the compelling advantages of laparoscopic compared to open. So I think we should continue to safely push the envelope as far as laparoscopic approaches, and even in my octogenarian patients, I will start, you just lower the pressure, make sure they tolerate. If they tolerate the pneumo, then you proceed and have a very tight communication with your anesthesiologist and let them know at any point you're happy to convert if their hemodynamics are not allowing the procedure to progress safely. And I think you can do minimally invasive surgery in a large number of patients if you have that type of communication. So thank you very much for your time.